Thank you. I'd like to thank Matthew Browne and Victoria Beedle for inviting me to be part of this forum, a very important forum because everything we do, our patients are at the centre of what we do and also at the centre of our research questions. So I'd like to start with the real human story. I mean, we started the whole conference with a fabulous human personal journey of one of our patients. Here are some more of our patients. On the left are two young men, Adam and Josh, with their two fabulous children. They had stage 4 melanoma and are now 6-7 years down the track doing incredibly well, living full lives with very big family lives. And on the right is Bert. And Bert was treated by my colleague, Alex Menzies, only a few doses of immunotherapy at the age of 101. And it speaks to how well tolerated drugs can be overall. He had a complete response, again, stage 4 advanced melanoma. And this is Bert at 105. So he's still alive, doing things for Melanoma March, which raises funds for important research projects to move the field forward. And he's done very well. So what I'd like to talk about are updates in treatments for advanced melanoma. And I've divided my talk into 3 parts. Where are we now? What is around the corner? And what about the future? So where are we now? Mark just eloquently went through very important aspects of early stage melanoma. And this is skin. We're talking about cutaneous melanoma. And so melanoma is divided into 4 stages. Stage 1 and 2 are the early primary melanoma. For example, Arnie Schwarzenegger there has one on his cheek, on his skin. Stage 3 is where the melanoma may spread to nearby lymph nodes. So if you did have one on your cheeks, it may spread to the lymph nodes in the neck. Stage 3 is divided into 4 substages. And as you go down a substage, your risk of recurrence after surgery increases. And then there's stage 4 or advanced melanoma or metastatic melanoma. They're all synonymous. And this is where the melanoma cancer cells escape from that primary lesion, get into the bloodstream, and then get around to plant their home elsewhere around the body, for example, the bone or the liver. So about 85 to 90% of patients have stage 1 or 2 melanoma. 10 to 15% of patients with melanoma have stage 3 or 4. And I'll be focusing on stage 4 melanoma today. So what about the general therapies we have for advanced melanoma? So there are 3 main modalities. There is surgery, radiotherapy, and drug therapy, and they differ in several regards. First of all, surgery and radiotherapies are what we call local therapies. They will treat just the lesion or the metastasis that you either remove surgically or that you direct ray beams, radiation towards. They do not treat multiple, unless you cut out multiple metastases. But drug therapy differs because what it's aiming to do is get into the system. And that's why we sometimes refer to drug therapy as systemic therapy, to try and eradicate those cancer cells that have got into the bloodstream and planted their home around the body. So drug therapy aims to treat all metastases in the body when the melanoma spreads. Metastasis is the word for where the cancer cell escapes and sets up home in places it shouldn't be, like the lung, the brain, or the bone, or the liver. There are 2 main drug therapies in melanoma: targeted therapies. At the moment, the targeted therapies that are approved are for those with the BRAF mutation. And in cutaneous melanoma, 40% of patients have a BRAF mutation in their melanoma. It's not something they've inherited. It's developed within the cancer cells. And BRAF treatments kill only cells that have the BRAF abnormality in them, so the cancer cells. They're tablets. Immunotherapy aims to activate what we call T cells. T cells are our important immune cells. They're also a subset of what we call lymphocytes. So lymphocytes are a type of white cell, and T cells are a specific type of lymphocyte that can kill nasties like viruses, bacteria, but also cancer and things that really should not be in our bodies. So what immunotherapy does specifically is it carefully stimulates T cells to kill cancer cells. Shown here is the 5-year overall survival rates in advanced melanoma for different modalities. So over a decade ago, chemotherapy was the mainstay, and about 8% of patients who had stage 4 melanoma would be alive at 5 years when treated with chemotherapy. The majority of patients died within the first 9 to 12 months. Our first drug to show a survival benefit was ipilimumab. That is an immune therapy, and the 5-year survival from that drug is 26%. We then saw the BRAF and MEK inhibitors. That's a targeted oral therapy, and the 5-year survival for those drugs is 34%. The next generation of T-cell stimulants, immune therapy, was anti-PD-1, and you may be aware of drugs nivolumab and pembrolizumab, and the 5-year survival for those drugs is 44%. And then combining one of the anti-PD-1 drugs with ipilimumab, so putting them together, we get the 5-year survival, our highest, of 52%. But there are a couple of questions. First of all, if you have the BRAF V600 mutation, what treatment should you have first? A BRAF and MEK, and then your immunotherapy, or the other way around? And then the other issue is the toxicity associated with dual immune therapy. So there are two areas. One we've already solved, and I'll show you data, but we're trying to find treatments that increase the survival but are not so toxic. So this is just hot off the press. This is a trial. These are Kaplan-Meier curves. I'm not going to be showing you many of these, but basically the trial starts at 1, and as time goes by, people die. We're comparing two treatments here. In the black, we're comparing when people got the immune therapy first, the Nivo plus Ipi, and then if they progressed, they went on to the BRAF-MEK. These are all BRAF mutant patients, or the other way around. And what we see is it makes a huge difference. In fact, there's a 20% difference in survival rates at 2 years. If you have the immunotherapy first, you do better. So in general, we advise on immunotherapy first for our BRAF mutant patients. So the other issue I touched on was side effects. These are the most common, fatigue, and these are side effects from the immune therapies because some of them are irreversible, whereas the side effects from the targeted therapies tend to be reversible. So fatigue, your thyroid gland can stop working, vitiligo, where you lose pigment of the skin or your lashes or hairs, a thick rash that can be quite itchy. Diarrhea or colitis is much less frequent with PD-1 alone, but is a possible side effect. And then any organ really can be attacked by the immune system, but these are much, much rarer side effects. For example, the kidneys, the eyes, the lungs, or the liver. And even rarer still are the nerves, but it is possible that happens, but it's much less than 1%. But it is a problem, and this is something we're focusing on. So how do we raise the bar above this 52%? That's a huge focus. We're focusing on areas of need, and one is resistance. So this is a patient who has melanoma in their liver. That's their liver there. You can see their abdomen and chest. And within a few short months, even though on immunotherapy, it's grown significantly. So this is one big area we're working on, drug resistance. Another is uveal melanoma, which has been very hard to treat when it spreads around the body, and mucosal melanoma. This is melanoma that's not associated with the sunlight, but that melanoma that arises from inside the body. The other area of great need is brain metastases, but we've come very far in recent years with treating this well. This is a patient with these white areas are all brain metastases. What we've seen for the 1-year overall survival in patients with brain metastases, it used to be only 8% with chemotherapy for 1-year survival. It's gone up to 30% at 1 year for ipilimumab immunotherapy, 44% for BRAF-MEK targeted therapy, 60 and 63% for combination immunotherapy. But if we then look at the 3-year overall survival, you can see again, this combination immunotherapy seems to hold that survival the best. And we're seeing cures of patients who have brain metastases. And when I say cure, I mean surviving beyond 5-6 years now and with no signs of melanoma. And this is an example of a patient with an excellent response. You can see their melanoma has disappeared by week 10. So what is around the corner? I'm running out of time, but just to highlight how we think about drugs and where we focus our attention, we're trying to get the immune system to recognize the tumor initially. So when the tumor first starts to grow, we then need to activate an army of immune cells once the immune system recognizes that the cancer is foreign and needs to be eradicated. We then have to move that army of immune cells to the cancer, the target, and then we need the army to kill the cancer. And this is just an example of all the drugs that we're working on. This is a very small subset, but you can see they work at different points in this immune cycle, and you can put them together in many different ways to try and help eradicate melanoma or other cancers. It's a very big undertaking to explore all of these drugs. But the good news is, what's around the corner, is we've had success with this LAG3, attacking the LAG3 on the T cell or blocking it. And I'll just show you here. I showed you the survival, but this is the progression-free survival. And what we've seen is very similar results to our gold standard, but much less toxicity. So this is a great move forward for the field. It's not yet available, but should be available in the coming years. I won't go through in detail other things, but needless to say, we're looking at all these different areas of the immune cycle. We've had some success with uveal melanoma. We've now got a drug that works by enhancing killing the target, and we use that in uveal melanoma. And also infusing T cells into people is showing some activity in the resistant group that I mentioned before. So what I'm going to do is just go straight to one area which I think we really should be trying to speed up this development of all these different drug combinations. What we're using now is the neoadjuvant therapy platform, where we give drug before surgery and then we cut out the melanoma and then decide what sort of response a patient has had. And these are all now our standard treatments. We've benchmarked them. We know what pathological response to expect. What I mean by that is we look at the microscope and see whether we have evidence that the melanoma is being attacked by the immune system due to the drug. And we can make decisions very quickly about whether to progress these drugs in clinical trials. But what's more is we get a lot of tissue so that we can try and look at what the best next treatment is going to be for those patients. So this is a big area of research. I don't have time to mention the microbiome, but we're working on that. And this is my last slide, because this is where we're going to be going. And this is a trial we're doing right now, where we test the tumor. We also integrate the melanoma features with the clinical factors. We look at the microbiome and decide whether a patient should have the standard treatment or whether they need to go on a clinical trial to try and match a better treatment to their tumor. This is still a big area of research, and we are starting that work in real time with patients in 2022. Lastly, clinical trials are important. If you participate in clinical trials, these are survival curves across all cancers. Patients who participate in trials do well, do better than those who don't. We've got many clinical trials in all sorts of settings, early stage, stage 2, 3, and 4, with drug therapies, but also other modalities. And it is important to talk to your treating team about participation in clinical trials. So with that, patients and their families drive everything we do, trying to push the field forward, and of course, all of my colleagues who work in the field. Thank you.